listeners. Welcome to the Onward podcast, brought to you by the Savetco Patient Resource Center at Baylor Scott and White, Dallas. Come see us anytime in Suite 200 of the Charles A. Sammons Cancer Center. We'd love to show you what we are currently up to as we attempt to provide as many access points as possible for cancer survivors and their families. And you don't even need to be receiving your care here at Baylor. We are here for you. This podcast is just one of those many points of access that we provide for you. I'm your host, Alan Wright, and with me today is my trusty sidekick, also a nurse, Erin Flemons. How are you doing today, Erin?
I'm great.
Wonderful. I'm excited to have with us today as our guest, Kelly Johnson, a genetic counselor here at Baylor Scott and White, Dallas. I'm really excited because although I work 2 doors down from you, I know very little about what you do as a genetic counselor. So I can't wait to hear more. But to begin with, just tell us a little bit about you.
Sure. So I'm Kelly Johnson. I'm a certified genetic counselor at the Sammons Cancer Center. I'm one of 3 here and been here for about 3 years. I have a master's in genetic counseling and a master's in public health genetics from University of Pittsburgh. And I'm originally from Maryland. Been in Dallas for about 3 years, just trying to survive the Texas heat.
Yeah, only 3 years.
Only 3 years,
I thought you'd been here longer than that. Wow, that's good to know. Well, you probably know what my next question is. What does a genetic counselor do?
Yeah, I get that question probably once a week. So we are a little bit of a specialized provider. There's different specialties of genetic counseling. There's cancer genetic counselors, cardiovascular genetic counselors. A lot of people are familiar with prenatal or pediatric genetic counselors that they see when they're thinking about getting pregnant. I specialize more in seeing patients that have a personal or family history of cancer or a personal or family history of heart disease. So what we do is we sit down with the patient. It's very much a discussion with the patient. We take a very detailed personal and family history to look at the different patterns in the family history, how things are running through the family, and see how genetics may or may not be explaining some of the diseases that we're seeing running through the family. And we talk to them about genetic testing and how that could impact their care and their treatment, but also how that could impact their family members. And if we know what people are at risk for, we might be able to screen them more proactively, hopefully prevent cancer, if nothing else, detect it early, and really, potentially save lives with some of this genetic information if we know what we're dealing with, basically. So our job is to help patients understand and adapt to the medical, psychological, and familial implications of genetic diseases running through the family.
So just sitting here listening to you and imagining being on the patient side of this discussion, I would imagine that you have to share some news that can cause people anxiety.
Yes.
And so are you trained to help people there too?
Yes.
Okay.
So we're trained, it's a little bit of an interesting training because we're trained on the genetics part of it and the science part of it, but we're also trained on the counseling side of it. So we do very kind of integrated training in both of those things and are a specialist in explaining complicated things to patients so that they understand it and they can explain it to their family members and really kind of take charge and make informed decisions about this type of testing.
Oh, I love that.
Yeah.
Well, you're invaluable. Yeah, I'm glad to be learning all this. This is that's wonderful to know. So listen, I know it's 102 outside, or it's going to get there today, but fall is upon us.
Yes.
And with that comes every month is a color. Teal blue for ovarian cancer, pink, of course, for breast cancer, among others. And so knowing that these months are already here among us, I have a couple of questions about those cancers specifically. Is it only the mother's side of the family that one should be concerned about when discussing breast cancer?
No. So a little bit of background on some of what we're testing for. So when we do genetic testing, we're testing someone's DNA or genes that they were born with. For every gene, we have one copy from mom, one copy from dad. And with this type of testing, we're specifically looking at cancer genes. So genes that we all have, they're good genes to have because they help prevent certain types of cancers from developing. And so we want those genes to be working for us. What we're trying to see is, are they working for that specific family or that specific individual? And if they're not, then they could be putting them at a higher risk for certain health concerns. So with breast cancer, we can get that information, those cancer genes, from mom or from dad, because it doesn't depend on sex, which parent it's passed down to, or which child it's passed down to. So it's something that we look at both sides of the family. A lot of people say, I had a family history on my dad's side of the family, but it's coming from dad's side. I'm not worried about it. But that's actually the opposite. We're just as concerned about dad's side of the family as we are mom's side of the family.
Well, let me get even more specific then. So we have a gentleman that comes here often. He is a breast cancer survivor.
Mm-hmm.
What about that? What if there's a history of breast cancer with the dad?
Yeah. We probably would be even more concerned, honestly.
Okay.
And there's certain risk, red flags that we look for in a family history. That would be things like younger cancers, so breast cancer under or at 45. Things like colon cancer, uterine cancer under age 50. We also look for multiple generations of people with the same type of cancer, people that have had multiple types of cancer during their lifetime, or rare cancers. So that would be things like ovarian cancer, male breast cancer, even pancreatic cancer. Those are kind of things that we start thinking about genetics when we see that in the family on either side of the family.
Okay, fascinating. So, and please tell me if I get any of this wrong. I hear of this BRCA gene.
Yes.
Is that, okay, am I saying that? BRCA to be specific. Is that the only genetic test for ovarian cancer?
No. So BRCA, as people say, actually there's two different genes that they're referring to, BRCA1 or BRCA1 and BRCA2 or BRCA2. Two separate genes. They just sometimes behave similarly, so people usually kind of use it all as one term. It's what people are most familiar with, and it is the most common genetic cause of breast and or ovarian cancer. It's not the only cause, though. People are just usually more familiar with that, and that's kind of what they're framing their understanding around. But now we know about 25 different genes associated with breast or ovarian cancer, so there's much more comprehensive testing other than the BRCA genes. And even if someone doesn't have a mutation in the BRCA genes, doesn't mean that they don't have a mutation in a different gene that also causes an increased risk for breast, ovarian cancer, or other types of cancers as well.
Okay, you may have touched on this a little bit already, but is BRCA1 or BRCA2 more important than the other?
Not really. They have slightly different risks. They, typically when we think of the BRCA genes, we think of breast, ovarian, male breast, prostate, pancreatic, and melanoma as the genes that could be at a higher risk if someone's BRCA genes or one of the BRCA genes aren't working. BRCA1 has slightly higher cancer risk on some things, but BRCA2 has a higher risk for things like pancreatic cancer or melanoma. So it just kind of depends what people are seeing in that family.
Okay.
Yeah.
Okay, now I've got another question kind of floating around in my head. We hear genetic testing. It's actually we hear it all the time. You hear commercials for genetic testing now.
Target.
Yeah, exactly. Yeah, Target, right. And so some of the most common we hear about is Ancestry.com, 23andMe is another popular testing. Are these the same kind of genetic testing that you're involved in?
No. So we get asked this so often, and we typically put genetic testing kind of two different categories. Kind of the clinical genetic testing that we order that people make medical decisions based off of, people have surgeries based off of that, they change their cancer treatment based off of that, and we test other family members for it. So it's really part of the medical care. And then there's what I call recreational genetic testing. And so that would be things like ancestry testing, which wine is my genes more compatible with? Do I have the curly hair gene?
Okay.
Things that people should not be making medical decisions based off of. And Ancestry and 23andMe really fit into that category. And they do have kind of fine print all over the place saying it's not a medical test, but it's pretty small and people just don't know what they're signing up for sometimes. Okay. I know people are curious, and that is one of the big things that has driven this so much so far, is because people want to know about their health and they want to know what they're at risk for so that they can be proactive, which I totally understand. Some things that I think people should be aware of potentially before doing those testings or gifting it to a family member is there are fine print, and to be aware of what limitations there are. So when you do those types of testing, you are giving them access to your DNA, and they can really do what they want with that, whether that's selling it to different companies, whether it's giving it to, police officers who are investigating a crime. Those are things that you are allowing to be done when you send in that type of sample, which not everyone wants. Another thing is that this is not a testing that has been validated in a lot of ways. So it has a high rate of false positives, actually. And so if we were to find some health-related concern with 23andMe, because they are starting to look at health-related genetic concerns, all of that needs to be confirmed with clinical genetic testing, because the laboratories and the techniques aren't the same. And sometimes something will pop up on 23andMe, but it's not found with clinical testing. And they found, honestly, that happens about 40% of the time.
Oh, that's terrible.
Yeah. And then on the flip side, they're looking at some things, but not everything. So someone could come back with, normal 23andMe, normal risk factors for certain types of cancers. But if they're not actually getting a comprehensive clinical test, then they're not testing for everything. So they could essentially get false negatives with that testing as well. So
thank you for that warning.
Yeah.
I've been tempted to buy one of these myself. I think I might refrain now.
If it tells you anything, I have not done this and haven't done it for any of my family members.
Sure. Wow.
But with that, also to be aware of, we find out things like non-paternity, and that family members are not actually what we think that they're going to be.
It's caused some drama.
I think we've all heard of some of that in the news or in our personal lives. And, just some limitations that people should be aware of. My general rule of thumb is if there's a reason to be concerned about genetics and the family history, then we should be doing clinical testing anyways. And then if people are curious about things, just kind of know what you are getting and what you're not getting with that type of testing.
All right, well, thank you. And so I would imagine, genetic counseling, that profession is always growing and new things are being introduced. So I know we've just talked about BRCA 1 and 2, but what's out there now? What is new to your...
So BRCA was new in the 90s, honestly.
Right.
And so quite a lot has changed. And honestly, the BRCA genes aren't even the most common cancer genetic condition.
Oh, wow.
There's something called Lynch syndrome, which increases the risk for things like colon cancer, uterine cancer, ovarian cancer, and kind of some other types of cancers. That is actually even more common than the BRCA genes, but people just aren't familiar with it or haven't heard it in the news. Those are also been around for a long time, but every week it feels like we're finding new genes that are at least preliminarily associated with certain types of cancers. So very often new genes are added onto genetic testing, and we're kind of learning as we go, honestly. And as we do genetic testing on more and more people, we find that there are more and more things that we maybe weren't expecting to find, and that there can be other cancers associated with that gene, and then are using that to really piece together some of the family history and explain some of the family history, and figure out what medical management guidelines are recommended for other people in the family that haven't had cancer before. But now there's probably about 100 cancer genes that could be tested not everyone needs testing for all of those things, even if there is a strong family history of cancer. So we really tailor genetic testing to a family history to see what are we going to find that would explain this family history, and customize it to the family that we're seeing.
Okay, that's a good segue into the one question I had. And how does someone that may think they need to see you, how do you receive a patient?
Yes.
Is it from a doctor? I can't imagine people just can walk off the street and see a genetic counselor, right? I mean,
yeah, so we this changes sometimes, and it may be different with different clinics that are seen across the country, and we're even in Dallas. And primarily doctors refer to us, and they go through someone's family history, or they're treating them for their cancer and they find out about the family history, or even just their personal history, and they refer them for genetic counseling, and we could kind of go from there. More recently, we have started to take more self-referrals. So if people have a concern for genetic counseling or testing, they can always call our office. And then if it's something that they don't have a doctor to refer to and there is a concern for their family history, then we can do a self-referral as well.
Okay.
Yeah.
See, I didn't know this.
This is a recent change.
Okay. I've learned all kinds of things.
Yeah.
Well, Erin, do you have any questions you want to follow up with?
The only question I would ask for you is if I'm talking to a patient, I say, my mother was just diagnosed with breast cancer, and she had genetic testing, and I really want to get tested for it. What's the cost
good question.
To the person who does not have a diagnosis of cancer?
So a couple things with that, to kind of add more information to your question. Just to frame the conversation as well, most people think that genetics explains much more of cancer than it actually does at this point. So whenever we do tabling events, we usually add like a trivia question out there, and we say, what % of cancer do we think is hereditary? So do you have a guess for that trivia question?
I think it's low.
See, I would have thought high, but I can tell by your question that I'd be wrong. I was thinking 45%.
45?
Or something along.
15?
15. It's actually about 10% of cancer is hereditary.
Okay.
So it is a minority of families that actually fit into that category, which is why we look for those red flags. Because even if someone has cancer, if they don't have those red flags in their family, very low chance that we're going to actually find a genetic cause for the family or a genetic mutation. So most people that have cancer don't get genetic testing. But when there is a concern, it is always best to test the person in the family who has had cancer first. Essentially, because if we're looking for a genetic risk factor to cancer, the person who's had cancer is going to be the one that we find that in most, or there's a higher chance that we'd find that in. Same thing as like strep throat, and we are testing a family member for strep throat. It's always best to test the person who has a sore throat first, because if they don't have it, then their siblings probably don't have it either. That's the ideal situation, is we test the person who has had a cancer diagnosis first. A lot of people think it's the opposite. They've already had cancer, they don't need this. But it's the opposite, that we need to test the person that's had cancer first, if that's possible. Some people have passed away, they don't want testing, and then we can always test the person who has been unaffected. Insurance doesn't necessarily change if someone's had a cancer diagnosis versus if they haven't, because it's still kind of a mix of personal and family history. So for someone who's had a cancer diagnosis, and they have their personal and family history, that could qualify them for genetic testing, or even if they don't have a personal history, if they have a strong enough family history, that could also qualify for them. When people qualify for genetic testing based on national guidelines, insurance usually covers genetic testing, and cost is typically based off of unmet deductibles and co-pays and things like that. If someone does not meet that criteria for genetic testing, or their insurance denies the testing, the cost of testing has gone down dramatically. People who had testing 10 years ago easily paid thousands of dollars for their testing, but now self-pay price for genetic testing ranges from $250 to $400.
I had no idea.
Yeah.
Wow.
Not to say everyone needs genetic testing because it's so cheap now,
Right.
but it has definitely reduced the barrier of cost for people who do
For
need
sure.
genetics.
Well,
And
that's great to know.
Yeah.
Yeah. Well, I've learned so much. Thank you. This has
Good.
been such an informative podcast today. It's interesting that I'm going to look at your office now, and I'm going to know what goes on in that office. But where science and psychology and
Yes.
compassion all meet together.
Yeah. It's a
And,
good way to point
I
it.
feel like I know so much more now. Well, thank you so much for
Thanks for having me.
being part of our Onward podcast today. I really do appreciate it.
Yeah, thank you.